I'm the specialty lead in anaesthetics in our DPU dental unit in Belfast, and I'd also like to confirm that I was invited today as a user of the Armstrong medical product, and expenses have been covered. I've included all the members of our team because we are very much a team effort in the unit, and we work all together, and 3 of us anaesthetists are actually interested in special care dentistry. Special care dentistry really is a service that is really concerned with the provision and enabling the delivery of oral health care for those patients who would be deemed with a disability or impairment. And when I say disability, I mean that in the broadest sense. It could be physical, sensory, emotional, intellectual, social, mental and medical, or a combination of all of that and all of them. And additional needs are required to deliver oral health care to these patients. This patient group has been recognised as not accessing healthcare, and in particular oral health care, and can lead to poor outcomes in this patient group. And we wish to avoid acute presentations in this patient group of poor oral health care in terms of dental abscess, difficult airways, maybe potential of Ludwig's angina, and difficult fibre optic intubations in an emergency situation. The British Society of Disability and Oral Health have recommended that special care dentistry is a specialty in its own right within dentistry, and this was only done actually as recently as 2009, and subsequently to then is now a recognised specialty with the General Dental Council. So our service is a consultant-based service. Since the development of this as a specialty, we have now got a consultant in special care dentistry, and our unit has just had our first CCT registrar who's CCT'd as a consultant in special care dentistry. This is Royal Victoria Hospital, and it's lovely and new and glamorous, but our unit is actually across the road in the School of Dentistry, associated with the Queen's University Belfast. And that's very good for patients in the fact that we do have a standalone unit as recommended, where our pre-assessments, our admissions, suite, recovery and theatre all are in the same area. That's great for familiarisation for the patients when they come for pre-assessment and then back for their treatment. However, for us as anaesthetists, it's much more daunting because we are isolated from the main hospital. We're the only physician in the hospital, in the School of Dentistry, and dealing with the patient group that we have who do have obviously challenging behaviours and challenging anatomy, airway, particularly airway anatomy, that can be quite daunting as well. So we've invested a lot of time in establishing the unit and having good practice, improvement of practice, improvement of equipment, and emergency drills if any subsequent adverse incident did happen. So anaesthesia and special care dentistry, there's very little literature reviews on this. There was a consensus document in 2009 really establishing this as an area that needs to be addressed, that needs to be recognised as its own specialty. And recently in June 2017 in the anaesthesia European medicine, they looked at basically use of general anaesthesia to facilitate dental treatment and special needs. And really the recommendations from these is that really we have to be very considerate of anaesthetising these patients under general anaesthesia. Because of potential complications, because essentially the main primary indication for the general anaesthesia in this patient group is lack of cooperation. We don't need a general anaesthetic to facilitate our dental treatment. So really this is a special group where you really do have to quite consider, and certainly the recommendations is to find other ways of sedation techniques to minimise the impact of general anaesthesia in this group. And quite often, we see these patients, all our patients are seen as in pre-op assessment, all are face-to-face with us as a group, an MDT group. And during that time, we try to confirm treatment plans where possible, because sometimes we can't even get to do an examination of the patients. We discuss with patients, again, where possible, and the carers or family, and sometimes consent and is not established, but we have a lot of best interest meetings and discussions around this area. A lot of my role is really obviously assessing medical well-being, airway anatomy, but it's also assessing the behaviour and the cooperation and compliance of the treatment of the patient to see what would be the suitable way to carry out this treatment. Some patients we do under monitoring only, and they would be more of the medical comorbidities that the community dentist is not happy to treat in their unit. But I say for the majority of patients, we choose either IV sedation or GA. And some of these patients, we also look at whether is this treatment suitable in our isolated but self-contained DPU, or do we actually need to refer these patients as an inpatient? And in our unit, this will be done in the main ENT theatres. And access to these theatres is very limited. We're dependent on the goodwill of other ENT or oral surgeons to give up lists, and it really leads to a lot of waiting time for these patients. We also assess for additional resources such as bariatric hoists, etc., that may help our care of these patients. So I say the recommendation is to move towards IV sedation with supplemental oxygen, obviously. And before high flow, we really only had nasal cannula, traditional nasal cannula, which really delivered 4 to 5 litres comfortably of oxygen. FI2 was 24 to 20%, sometimes maybe 30%. These were cold, dry gases, and Stephen's already highlighted the impact of that on the mucociliary function of the airway. And obviously, given higher than 4 litres, I've actually seen somebody try to give 10. It's like the jet stream going into the back of the nose. And with limiting the amount of oxygen you give also limits the amount of depth of sedation. And there's a lot of regulation and guidelines on conscious or unconscious sedation. And really, with our patient group, and to improve compliance, we needed really a deeper sedation level to carry out and complete treatment plans for these patients. So obviously there was a move then with the introduction of high flow. I have worked with high flow in other areas of my clinical practice. I'm a obstetric anaesthetist. I also do trauma and orthopedics and a lot of spinal surgery where I've been using high flow for pre-oxygenation, fibrotic intubation, and we've actually used it for post-op critical care in the labour ward as well for a number of patients. I'm not going to go through all the benefits of high flow, as Stephen's actually already outlined that. But the move to this has been absolutely fantastic for us in facilitating a kind of safer and deeper sedation. We do, with the mouth opened, we obviously do lose a lot of the PEEP effect, but a lot of it is really with airway, is really around the upper airway and maintenance of a patent upper airway with us as well. This is our setup in the DPU. We have 2 theatres, one with a standard operating theatre and bed operating table, and one is with a dental chair. For some of those patients who we feel that maybe will try sedation, but we might have to revert to GA, we do them in the theatre 1 with a operating table that can be made into a chair and then put back as necessary if we have to proceed to general anaesthesia. We use total intravenous anaesthesia, which is obviously the choice sedative here with propofol, and it's full monitoring, and we have fully equipped with anaesthetic machine again if we had to intervene in any way. The patients also quite often use a prop for the deeper sedation. The dentist use a prop for the airway to maintain the airway open during treatment. On occasion, some of the patients have a lot of access oral secretions, a lot of drilling, and we may use glycopyrrolate there to dry the upper airway a little bit in terms of that, because you can get pooling of secretions in the back of the throat, and with the prop in, they do have a limited ability to swallow. So on occasion we can actually ask the dentist to remove the prop and let the patient swallow and clear some secretions. All our dentists are trained in jaw thrust as needed. Quite often you have to remind them, because they do tend to push back on the mandible when they're doing extractions, but we're very vigilant actually during this procedure. Obviously the nasal interface is very comfortable. It's soft and sits well in the space and allowing full access, and then more recently with the interchangeable nasal cannula from side to side, it actually is an advantage to us because most of our surgeons our dentists work from the right side. So we've been using high flow since 2016 in our unit, and really it was a case that really brought it into the unit. As I'd been accessing high flow in my clinical practice, and basically we had the patient, a 45-year-old patient. She had generalised dystonia, quite marked movements. She had a previous tracheostomy from a prolonged critical care admission and had some residual stridor in basically while awake. She was also deaf, needed an interpreter, and she had severe dental anxiety. So previously we had attempted sedation with traditional cannula, and unfortunately we couldn't complete that treatment to get enough sedation to minimise her dystonia. And it was a situation of worsening stridor, airway obstruction, and basically we had to abandon treatment. So we considered options. Were we going to do a GA in this patient? Should we do it inpatient or in DPU? Or should we try the high flow? And actually, this was the first case that brought the high flow into the unit, and we give it a big hug, and it has remained there ever since as part of our practice. And it was absolutely fantastic. We had an hour-long procedure where the patient had all her treatment done, and she had no episodes of stridor. Obviously the flow and the positive pressure really sort of splinted in the area where the previous tracheostomy was, and there's absolutely no desaturations at all. And we were able to give her a level of sedation that was allowed control of her anxiety and obviously her dystonic movements. So using high flow in special care dentistry facilitates safer sedation. It facilitates obviously deeper sedation too. So our more challenging patients where deeper sedation is needed for compliance and behaviour. So the benefits, again, I said, challenging patients, challenging airways. Say a lot of these patients with the disability have other dysmorphic features and difficult airways. Also, we have obese patients within this group as well. And not only in sedation, we found benefits, obviously, with general anaesthesia. We've used it in the unit for pre-oxygenation in some of the obese patients who did require GA. We've used it for fibre optic intubation, and prior to the introduction of high flow nasal oxygen, we didn't do any fibre optic intubation in the unit in DPU. Whereas now we can plan to do that, and the use of the fibre optic, a sleep fibre optic. Obviously, awake is not suitable in this patient population, and we've used it in the post-GA recovery period for a short time. Another patient we've done is a 21-year-old lady, severe dental phobic and severe mental health issues. She had and was morbidly obese, her BMI of 44, and her airway, her body morphology gave it rise to assessed as quite a high airway risk. Her previous treatments had been done as an inpatient and under general anaesthesia. So we felt we could try and move this patient on, and not, obviously our waiting time actually for inpatient referrals was now at this stage a year, and we wanted to get her treatment done in a much more expedite fashion. So we felt that maybe using IV sedation with high flow nasal oxygen and DPU was an option. It did take quite some time and quite a number of visits to counsel this lady into actually proceeding with sedation under high flow. Sometimes her mental mind was that she was having a GA and that was it. But however, we did talk her into it, try to gain her confidence, gain her trust. And really this was a very successful treatment in the DPU with sedation and high flow and without complications. Her recovery was short, obviously with the use of TIVA, and uneventful. And we do see this as a stepping stone for some of our patients. We have moved patients from repeat GAs, which is obviously not ideal in this for dental treatment, to moving them to sedation. And with a plan, maybe we can actually move some of the patients back to community again. So it is a more work individually for each patient, but we feel it's a pathway that we can get some, obviously not all patients, back to the community. The benefits of high flow. And with point, obviously, in our unit, we didn't have piped medical air. So initially, we were using a delivery device that was only 100% oxygen delivery. And the increasing amount of sedations we were using and the prolonged sedations, we were doing sedations and treatments plans up to an hour and a half. And on 100% oxygen, we were kind of trying to get away from that. So Armstrong Medical had done a presentation in our anaesthetic department audit, actually this time a year ago. And we first got to know about point and the ability to reduce that FiO2, and particularly in our unit, it seemed to be very useful because as we didn't have piped medical air, so there was entrainment of room air. And I also met Medical Armstrong Medical at the Difficult Airway Society in November last year. So obviously we were said moving away from 100%, being able to and give these patients reduced FiO2 was deemed as much better. Obviously, the science in mine, and I can't flick my hair, is that nitrogen, obviously 100% oxygen does wash out the nitrogen. You will get end alveolar collapse and maybe result in ectalysis. And obviously prolonged 100% oxygen exposure can lead to endothelial damage and post-op hypoxia. So the impact in high flow nasal oxygen on our services, really, we really felt that this was now an increasing choice of anaesthetic technique for sedation. We wanted to look at what we've been doing over the last few years, look at the change of practice, and see if it had any impact on the patient's access to care, which is obviously very important. We want to remove barriers for that, and on their outcomes as well, and on our overall service delivery. So we did a literature review. We also reviewed cases, including 2 that I've presented already, and we looked at our own TMS data from our theatre management system in the unit. Literature review really only revealed one previous study using high flow nasal oxygen for dental treatment, and it was a randomised controlled. There was 30 cases. They had divided them into 3 groups of 5 litres of oxygen, 3 traditional nasal cannula, high flow with 30 litres and high flow with 50 litres. And really, basically, they found that there was decreased interruptions, decreased desaturations to treatment with the high flow. And basically recommended further studies for whether 30 or 50 litres were the ideal. But obviously, that's a greater patient, operator, and anaesthetist satisfaction. Looking at our own TMS data, we analysed 2014 or 15 to 17. 2015 was essentially the last year we hadn't got high flow in the unit, and 2016 we've increasingly used that the high flow. But overall, we did find a reduction in the number of GAs that we're doing. We did find an increase in the patients that we were putting through, and obviously it was statistically significant, the numbers between sedation and change in GA to sedation. And also we found that there was an increase in anaesthetic technique for the higher risk patients who previously we might have referred to as an inpatient. And we found that we can actually manage these patients now without a GA and with high flow, so improving their waiting time and access to care as well. So these were essentially our numbers, and really essentially you can see on the right side that our numbers have been increasing in terms of the number of cases requiring GA or sedation, but there is a decreased number of cases taken under GA and an increased number of sedation cases, and this has been facilitated with the use of high flow. So really, high flow with IV sedation is superior in maintaining oxygen saturations during treatment. It does facilitate deeper sedation in challenging patients. Less, as the other paper found, we have found less interruptions to dental treatment and more rapid recovery and earlier discharge. With general anaesthesia, you would find that we find much more emergence, delirium or confusion, aggression with some of this patient group. We found also increase in post-op nausea and vomiting in that group as well. So, and particularly with some of them who required inhalation induction, we've just found this was a bit more prominent. So, using TIVA really definitely did improve patients' complications post-op. And we also found that we had actually no unexpected hospital admissions for dental treatment with high flow and sedation to date. So, normally in our unit, say we have 7 lists a week. 2 of those are oral surgery, and 1 is a pre-assessment, and we would have about 3 to 4 unexpected admissions from DPU, and really they're really in relation to GA and post-op, mainly cardiorespiratory complications. So with this increase in use of sedation, this group have not had any admissions. And I say we've reduced the number of high-risk patients for inpatient referral. So it is an increasing growth in our service, and we're trying to maintain expand our consultant-led service over the next few years. So essentially, there's many challenges. Repeat of previous slide. There's many challenges, but it definitely high flow with IV sedation is an increase in anaesthetic choice, safer sedation, and it does essentially increase access to care. It has decreased the waiting times, and I received an email from one of the admin team to congratulating us on our decrease in our waiting times to less than 11 weeks, which had been the first in many years, over the last few years with this treatment. And we are an MDT team, and high flow has now very much become part of that team. Okay, thank you.
Are there any questions?
Thank you very much for that talk. Yes, they're a very challenging group of patients, and it's a very good way of doing them, I think. It's just one of the slides you referred to the maximum flow, about 120 litres per minute. Is that correct?
Yes,
now, what is
the blender airflow or the Venturi one that we have will allow that. It uses in trainer, but we don't use up to that. But you can go up to 120 in the.
I mean, I'm wondering. I don't know if I should ask you or Armstrong Medical, but what is the recommended maximum of flow? Because I was told it was 80 now, I think. And is there any benefit of increasing more than 80 if you're getting 89% in the orifice?
Let them answer that. We don't. I don't use 120,
Sure.
but it's the facility in that particular machine. When you don't have piped oxygen, will allow that. But we said it. We usually start at 40.
Okay, thank you.
The current conventional thinking is that the maximum for high flow nasal therapy is in a window between 70 to 80 litres per minute. The device that Mary describes, we have an ability to push to a higher level of flow with specific use for those patients who present post-operatively who are atelectic, and the device can be modified to deliver a mask and peak valve method of CPAP. Hence, the higher level of flow is needed to meet the patient's peak inspiratory requirement to make sure that we deliver true CPAP with a continuous descending pressure.
Okay.
So there is another application these devices can deliver with very small modification, and that's where the higher flow is available.
These are used in our wards for respiratory and cardiac patients with, but not in a HDU setting.
Thank you.
Anybody else? Okay.
Oh,
Sorry,
I mean, it's great to see that. Luckily, I suppose in some respects we do a lot of paediatrics. We don't with these kids. One of our other hospitals does it, and it is a challenge. And they tried to move it recently to our hospital, and we weren't that enthusiastic because they're a very challenging group of patients to look after.
We are 13 years and above.
Yeah, so you're
so
well practiced.
Vulnerable adults, we don't do.
We don't.
In our unit,
Yeah.
Currently, we don't do below 13.
Okay.
So they are done in the paediatric hospitals again on the same site.
And then,
But they will grow into us.
They will eventually. You can't get away from them. But I mean, your sedation technique is working very well. Have other colleagues in the brand new bit of the hospital have said, "We come over and see it. Can we use it?" Because I think sedation and us as providers of sedation, I think, is going to start increasing. I think people are going to try and move away from general anesthesia for some procedures, and I think we've got to be very engaged with it, because otherwise we'll end up with deep sedation with the problems that we see in our general hospitals with sedation that's poorly performed and managed and monitored, to be honest. So has anyone said, you know what, we would like to try sedation on some other procedures, and have they expanded that into the
because we were that isolated, people didn't want to come to us initially, so we actually are, because we've been kind of speaking about the work we've been doing. We've actually now got a few more consultant anaesthetists who are coming through with us. Obviously, in terms of sedation, we do very much teeter to effect. We try not to use, obviously, we don't use ketamine. Try minimal midazolam. In fact, probably we're using more buccal midazolam, and that's really because some of these patients just need buccal midazolam even just to get into the chair. We use, obviously, topical local anaesthetic, but even just to get in, and everything's about de-stressing. I don't like to use too much buccal because I do find it has a residual effect at the other end, so I try my best not to. Sometimes we use combinations of Rapifen as well, or alfentanil with the propofol, again, that sometimes minimises the coughing potentially as well. But yes, we actually are getting more popular, I should say.
Good.
Trainees are also seeing the work, and trainees are now requesting our list, where we tend to not have trainees because they were prioritised to the major head and neck and all the other specialties that they need to have in terms of their competencies. So actually now we've been inundated with trainee requests to come and see the work, and they're really impressed, and they get hands-on to use the high flow as well. And again, yes, using sedation techniques is really So we're getting out there.
Thank you.